Autophagy's intricate relationship with cancer has positioned it as both a target and a tool in modern oncology. Unlike conventional treatments that aim to directly destroy tumor cells, autophagy-based strategies attempt to manipulate a fundamental survival mechanism that cancer cells often hijack for their own benefit. But because autophagy can either suppress or support tumor progression depending on context, its role as a therapeutic target is highly nuanced, requiring careful calibration based on tumor type, stage, and the overall biological environment. In early tumor development, autophagy is generally protective, preventing the accumulation of damaged cellular components that could trigger malignant transformation. However, once a tumor is established, especially under stress conditions such as hypoxia or nutrient deprivation, cancer cells frequently upregulate autophagy to survive. This is particularly evident in aggressive and fast-growing tumors that outpace their blood supply and need an internal recycling mechanism to sustain their energy needs. In these scenarios, autophagy acts like a metabolic crutch, helping cells adapt and resist treatment. As a result, one therapeutic strategy involves using autophagy inhibitors to cut off this lifeline. Agents like hydroxychloroquine and chloroquine, originally developed as antimalarials, have been repurposed to block autophagosome-lysosome fusion, disrupting the final step of autophagy and sensitizing tumors to chemotherapy, radiation, or targeted therapy. But inhibition is not the only approach. In some cancers, especially those with defective apoptotic pathways, inducing excessive autophagy can lead to a form of programmed cell death distinct from classical apoptosis. This form, often called autophagic cell death or type 2 cell death, occurs when the process is driven beyond its survival threshold, leading to self-digestion and collapse. Certain drugs, such as arsenic trioxide or histone deacetylase inhibitors, aim to push cancer cells into this destructive autophagic overdrive. Similarly, metabolic interventions like fasting-mimicking diets or the use of autophagy-inducing compounds like rapamycin and spermidine are being explored in combination with existing treatments to amplify their anti-tumor effects in specific contexts. Yet these strategies carry inherent risks. Systemic autophagy inhibition, while potentially effective against tumors, can impair normal tissue homeostasis, especially in organs with high turnover such as the liver, kidneys, and brain. Over time, this could lead to toxicities or accelerate aging-like effects. Likewise, inducing autophagy broadly without selectivity might protect rather than harm certain tumors, particularly those that rely on autophagy to avoid cell death under therapeutic stress. This paradox means that therapies must be tailored not only to the tumor's genetic and metabolic profile, but also to the patient's age, immune status, and comorbidities. Moreover, tumor heterogeneity further complicates the picture. In some cancers, subpopulations of cells may be autophagy dependent, while others are not. Targeting one group could inadvertently select for more resistant clones. And in tumors driven by oncogenes like KRAS or BRAF, autophagy often supports tumor growth and resistance, whereas in others, its loss may correlate with poor prognosis. This variability underscores the need for predictive biomarkers to identify who will benefit from autophagy modulation and when. Nonetheless, ongoing clinical trials are shedding light on how to harness autophagy in combination with other treatments. There is growing interest in using autophagy inhibitors alongside immune checkpoint blockade to enhance anti-tumor immunity, as autophagy can regulate antigen presentation and immune evasion. Additionally, efforts are underway to develop next-generation autophagy modulators that act with greater specificity and fewer systemic effects. What makes autophagy such a compelling target is also what makes it dangerous to approach without precision. Its role in cancer is neither straightforward nor uniform. It bends and shifts according to cellular context, disease stage, and therapeutic pressure. Like a double-edged sword, autophagy can be a shield or a weapon, and wielding it effectively requires deep understanding, not just of cancer biology, but of aging, metabolism, and immune regulation. As researchers refine the tools to manipulate this ancient survival pathway, the promise of autophagy-targeted therapies lies not in blunt force, but in their capacity to strike at the vulnerabilities unique to each tumor's life cycle.